Hello everyone, welcome back to the Tokyo Living Podcast. Today we have on our resident physician, Dr. Tom Lomax. Tom, thank you very much for joining us again, and thank you very much for hosting me in your clinic today.
Yes, you're welcome.
Today we're going to be talking about the new spotfire assessment for respiratory infections.
Yes.
Perhaps if we can just build a background by talking a little bit about what respiratory infection is, the differences between bacterial and viral infections, and I guess a little bit of a history of the testing methods and how they have progressed and how we've got to this point.
Okay, so that respiratory infection is probably the most common reason for anyone to come and see their doctor. So in primary care, every day I'll see people who've got a new onset respiratory infection of some kind. So people will come in with some combination of a runny nose, a cough, a fever, a headache, a sore throat, and then maybe sort of general fatigue as well. Not all of those symptoms usually, but a mix of them. I guess historically, if you go back to the 70s, if you had those symptoms, your doctor would just give you antibiotics. So if you talk to doctors who sort of trained back in the day, because you knew that some of those people would have bacterial infections, so they'd have a risk of having or developing a pneumonia. You didn't want that to happen. Antibiotics were the great wonder drugs of the 50s and 60s, so they were just literally prescribed to everyone who went in, even people who just had like early onset symptoms of like a blocked nose. Okay. So kind of fast forward to when I was training, we started to have a better understanding that actually the majority of people who have those symptoms don't have a bacterial infection. And yes, if you give them antibiotics, they'll get better, but equally if you do nothing, they'll get better and with less risk of having side effects from the drugs. Sure. So the game sort of evolved to trying to figure out who was going to benefit from antibiotics and who should have symptomatic treatment with watchful waiting, basically. So we'd sort of started to try to make a clinical decision, like what features of people's symptoms could you tease out and use to kind of better inform your decision. But in the early stages of respiratory infection, there's often no difference. Right. So you actually are sometimes just guessing. Sure. And then you have to either err on the side of caution and give too many people antibiotics, or kind of, if you take the public health approach, like in Northern Europe, there's a sort of push not to overload doctors, to only start treating people 4 or 5 days after they've gotten sick. But then, of course, by then, some people are really quite sick, so you've missed the opportunity to sort of nip some serious infections in the bud. Right. Okay, so with that in mind, obviously testing is extremely helpful. And I guess even sort of 20 years ago, there were rapid tests. So, like for COVID, there's the rapid antigen test, those kind of tests for some particular things, like for influenza, for example, or for strep throat. So most of us are familiar with having an assessment, then having a swab taken and having a quick test done. And, that gives us some information. But still, even with rapid tests for influenza and strep, probably that only covers about 10% of respiratory infections. Right. So you can pick out those 10%, and in certain times of the year, like in the middle of the flu season, you can sort of get more people, but a lot of the time you are still just left with, well, it's not influenza, it's not strep, we don't really know what it is. Yeah, okay. So I guess the next thing that really changed diagnostic testing was COVID. So as we'll all remember, there was a real pressing need to identify COVID patients. And initially, back in 2020, we were after PCR tests. And at that time, PCR tests were in very short supply. So I think in early 2020, nationally, Japan was doing like between 500 and 1,000 PCR tests for the whole country. So it was very, very difficult to get a PCR test done. Obviously, that was massively expanded during COVID. Yeah. PCR tests always took at least 24 hours to turn around, and sometimes longer, because the PCR devices took at least 4 hours to run the analysis, and they were big devices, expensive, held in big hospitals or labs. So samples had to be transported, then data had to be sent back. But PCR is very accurate. So it did give us a sort of very certain diagnosis for COVID. Now, just in the last 3 years, there's been a further rapid evolution in testing. And spotfire, which I'm going to show you today, is probably the most, it's the most recent iteration. So this is a PCR device, but it can run a PCR test in 16 minutes. So it's good for point of care. I can see someone run the test and give them the result all in the same visit. And it can test for 15 different infections off a single swab.
So perhaps if you can maybe show us how the device works, and then while we're actually running a test sample through, we can talk a little bit about what it's actually doing.
All right, so this is a live sample. This was taken from a patient this morning, a child who came in with a 48-hour history of a 40-degree fever. So I'm going to wear gloves and a mask for 2 reasons. First of all, the sample itself is potentially contagious, or it carries infection. And secondly, it's an extremely sensitive test. So if I breathe on the sample or touch it with contaminated hands, I could introduce genetic material from another infection and mess up the result. So we have to be quite sort of careful about maintaining safe conditions during testing. So here we go. This is one kit for a single test, and these are the wells for the 15 different infections we're going to test for. There we go. There. Reagent, and we've got there. So this is relatively fiddly. There we are. That's loading in the reagent on one side. This is the sample. So this is taken from a nasal swab. I mean, again, talking about COVID, at the beginning of the COVID pandemic, we were doing the deep swabs from sort of all the way at the back of the nose, which people really hated. This test works fine with an anterior nasal swab. So you just have to swab the front of the nose and then collect the sample. So that goes in there, and then more reagent goes in after it. A whole lot of that. Then close that and inject that on the other side of the rack, like so. So that's good to go now. There, load that back in there. And this is our machine here. So now we've got it ready. Basically, it's as simple as just loading it in. Okay, it's about to make a big noise. Just wait for a second. I'll start talking after the big noise. There. So now the sample's in, I can take the gloves and mask off. This is running a PCR test now. So it's going to take another 16 minutes before it completes. And it's then going to give us 15 separate yes or no answers. So it's testing for 4 different bacterial, another big noise. It's testing for 4 different bacterial and 11 viral infections. Okay, so we can look at the full list when it finishes running, but that includes, amongst other things, COVID-19, non-COVID coronaviruses, and 4 different strains of influenza, plus a number of generally less severe, less serious respiratory viruses, and 4 bacterial infections.
So while we've got that test running, perhaps if we can just talk a little bit, without getting too technical, about what a PCR test is actually doing, how it's actually making that diagnosis.
Yes. Okay. So PCR is basically detecting tiny traces of genetic material, and the reason it's so sensitive is it amplifies the genetic material it finds. So you're looking for a piece of DNA or RNA that's unique to the organism you're testing for. You're amplifying that millions of times, and then you're detecting the genetic material afterwards. So that means that even with only a tiny trace of genetic material, get a positive test, which is in contrast to rapid antigen tests. So the tests we're familiar with from doing at home, where you just, it looks like a home pregnancy test, basically run it on a little plastic slide. Those are looking for viral protein, and they need quite a lot of material to generate a positive test. So for a rapid test to give a positive answer, you probably need about 1.5 million viruses on the swab, whereas for a PCR test you need about 50. Okay, so it is much, much more sensitive and much more accurate.
And how has the technology made this so efficient, going from a 24-hour test to a 16-minute test? What has been sort of the advances that have allowed for that?
So basically it identifies a genetic fragment, and then in a cyclical manner it doubles that fragment. So it does one cycle, and if there's one fragment of genetic material, after one cycle there'll be 2, after the second cycle there'll be 4, after the third cycle there'll be 8, and after 30 cycles there'll be millions, right? Old PCR devices needed about 20 minutes per cycle. So if you're going to run 30 cycles and each one was 20 minutes, the whole thing would take hours. So basically they would run overnight. Now that's been condensed down to run sufficient cycles in 16 minutes. Plus the machine's been made much, much smaller. Yeah. So it's actually using the same technology. It's just been engineered to run much, much faster, and the whole kit is much smaller. The machine itself is quite expensive.
Yes.
So that costs about as much as a new car. Right. So the upfront cost of putting it in place is non-trivial, and I mean that's why probably uptake and availability is going to be relatively slow over the next few years.
Yeah, I guess that was my next question. What sort of proportion of clinics in Japan are currently using this? Is it something that is more readily available now in the West, in the UK, Australia, United States, Europe?
I think in the US it's becoming fairly readily available. In Japan, it's actually been funded by some municipal health authorities. Yeah. So Tokyo Metropolitan Government has provided the machines to a lot of clinics. So quite a few clinics in this area will have this set up. The problem is that the reagents, I mean, as you can see, all the disposables we use are quite fancy. So, I mean, the material cost of running one of these tests is about 15,000 yen. So even if local Japanese clinics have the setup, Japanese health insurance still won't pay for the test. So if you go in and see like a regular Japanese health insurance clinic doctor and you want this test, you still have to pay out of pocket for it.
So from the side of the care provider, how has this helped you in terms of your treatment, and what are some of the things that you're seeing diagnostically following the results of this?
We've only had this in place for 2 months, and actually it's been like a real eye-opener for all of us. So, I mean, the first thing that we picked up is there's a lot of influenza circulating this year. Normally we expect to see the winter flu outbreak in sort of January is usually the peak month. But this year we've seen like a whole ton of influenza A sort of from early October. Yeah. So it's helped us identify early influenza outbreaks. And I mean, identifying them helps limit them because it keeps kids out of school, lets schools know that there's multiple cases in a single class, so it gives you better opportunities to limit spread through the community. We've seen a few mycoplasma cases. So mycoplasma is a bacterial infection that can give you sort of lower respiratory kind of cough and breathlessness symptoms that go on for several weeks if not treated. Again, we were kind of surprised to see quite a high number of those. And we've seen quite a lot of seasonal coughs and colds, as we kind of expect. So this will help us positively identify viruses like RSV or rhinovirus, which aren't particularly nasty. But of course, if you can tell people, yes, this is just a regular virus, you're not going to get more sick, and without treatment you should get better in a few days, then it's quite reassuring. Okay, so we're nearly there. Just to remind you, the sample that we're running this test from here, this was taken from a child earlier on today who came in to see us with a 2-day history of 40-degree fever. So on the basis of the symptoms, we're looking for, I guess, an acute bacterial infection, a viral infection could be one of many. And I guess particularly this time of year with high rates of influenza circulating, we want to know if they have influenza. And there we go. Okay, so let's have a look and see the results. So we've got, in the event, 2 positives. So this sample has tested positive for both influenza A, which is the seasonal flu, and also para-influenza virus. Now, I mean, as I mentioned earlier, it's a PCR test. It's super sensitive. So if you've had any infection in the past month, it's going to detect that because there'll be residual genetic material in your nose. So I suspect with this child, what's happened is they had a mild cough or cold a few weeks ago, and that was the para-influenza virus, which we're still testing positive for. But the symptoms they have now are acute influenza. So I'm presuming, because I didn't see this person, they would have been offered antiviral therapy for that.
So Tom, thank you very much for coming on the show again today and talking us through this technology. I think it's something that will be very useful, not only at the individual level, but also, as you alluded to, for communities, helping to spread, or stop the spread of viruses.
Yes. Yeah, thank you very much. No, I mean, I think this is relatively new for us. We're very excited about it, but I think this technology is going to extend into other areas. So at the moment we can only run the respiratory panel, but the same company are working on a panel that will provide a panel of tests for gastroenteritis, so people who've got acute gut symptoms. And I think generally it's going to get faster, cheaper and more available over the next few years. So it's something that I think we should continue to watch. Thank you very much.
So thank you very much for watching and listening. If you do have some other topics that are relevant to healthcare in Japan that you would like Dr. Lomax to speak about on a future episode, please let us know. Thanks for watching, and we'll look forward to speaking with you on the next episode.